it's a lot more complex, and so sometimes it can be harder to get down to the root of it. It's harder to assess avoidance because people's roles and social environment change. And so they may be getting support at home, and you don't know if that's because of a physical disability or if it's because they are having some phobic avoidance of leaving their home, for example. And they may have less contact with provoking factors overall because they're these different expectations about older adults and what they are, how much they do. And a bit of stigma around that as well. If an older adult's not doing very much, we might just think, oh, that's normal, they're slowing down. It can be also hard to assess the idea of excessive in an older adult. If someone is anxious about falling, and they have fallen before, and the consequences of falling are not great, how do you say that their fear of falling is actually excessive? And we'll come back to this again a little bit later. So these are why it can be a bit hard to diagnose anxiety in older adults. But I do encourage people to make use of assessment scales for anxiety. There are a couple of geriatric specific ones that are quite good that were designed to really minimize overlap with somatic illnesses. Because there is such a big overlap in older adults between anxiety and depression, the hospital anxiety and depression scale is great. You get, two birds, one stone in one screening tool. So if you're in a position of making a diagnosis, the first thing you really want to understand is, when did the anxiety start? Is this an exacerbation of someone's lifelong anxiety problem? Or is this really a late onset anxiety? And what were some of the provoking factors? Before you get to the idea of an anxiety disorder, you really want to think about whether the anxiety is symptomatic of another condition. So are they depressed? Is there cognitive impairment? Is there physical illness? Is there something physiological going on that is, affecting this anxiety? And then you come to the idea of whether there might be a primary anxiety disorder present. So generalized anxiety disorders is one of the most common ones in older adults that is diagnosed. It is really about more chronic anxiety. You're meant to have this anxiety present more days than not for more than 6 months. Multiple excessive uncontrollable worries, but one of the challenges here is that few older patients present really with anxious mood. But these are people who are coming present often to their office, lots of unexplained physical symptoms, lots of health-related worry that seems, excessive to the actual situation. Really huge overlap between generalized anxiety disorder and depression. So, if you have 4 people presenting with generalized anxiety, probably 3 of them have comorbid depression with that. And that's really important to know, because especially if you have someone presenting with anxiety more acutely, like that's only been a month or 2 that they've been more anxious, you don't have to wait 6 months, to make a diagnosis. You might consider in that moment whether this acute worsening in anxiety might in fact represent depression. And there's a lot of shared underlying neurocircuitry and symptoms in common. And so it's actually not hard to make those diagnoses. And in the DSM, it used to be that you couldn't diagnose GAD and depression at the same time, but that's changed now. So they've recognized that there is this, anxious depression that is not uncommon. And it is a marker for more difficult to treat depression. I'm going to move on to agoraphobia. And this is actually something that I almost never see because people who are agoraphobic don't come to psychiatric attention very often. And people become agoraphobic for a lot of different reasons. The focus used to be really around panic attacks being the main reason. But now we recognize that people become agoraphobic when they have a fear of situations where they might be incapacitated or be embarrassed. And so in older adults, I see sometimes people become agoraphobic because they're afraid if they go out that they might fall and not be able to get up, or they might be incontinent, or they might throw up or have another kind of physical symptom that they perceive as embarrassing or incapacitating. The other reason why this is not a diagnosis that's made often in older adults is that a lot of older adults won't leave their house unless they say have a family member with them, but they will go out with a family member. And actually, you can make a diagnosis of agoraphobia if they only tolerate these situations if they're accompanied by somebody. But again, the challenge can sometimes be, are they not leaving their home because of their physical disability, and they only leave with their family member because they're there to, support them? Or is there an actual mental health issue that's contributing to this? And so often quite difficult to diagnose. So fear of falling is probably a lot more common than we realize. Probably around 3% of older adults get into a situation where they're not leaving their houses or yards because they're afraid that they might fall. As I said earlier, this could be diagnosed as agoraphobia. It could also be diagnosed as a specific phobia if they really have a fear of injury from falling or a fear of walking, for example. And one of the challenges here is that it's relatively easy to make this call if someone is developed fear of falling in the absence of falls. Like they haven't fallen, they're just so worried that they might fall that they develop some really severe activity restriction. But it's a bit harder when someone does have a history of falls, and this is where a falls risk assessment can be really valuable. So if their falls risk assessment is sort of lowish, but their fear is really high, then you can pretty much see that there is an excessive fear there. And that in many ways, the sort of behavioral avoidance that they've developed is probably counterproductive, right? They're actually increasing their risk of falls by limiting their physical activity rather than reducing it. And so anyway, so that we can also talk more about this later, but this is, I think, an anxiety disorder that it will increasingly being diagnosed in older adults. I wanted to just touch on anxiety associated with dementia. It's a very common neuropsychiatric symptom, probably a bidirectional relationship where people who are anxious are more likely to have dementia, but people who have dementia are more likely to become anxious. When you have cognitive impairment, you start worrying about forgetting, making mistakes in your day-to-day life. You can feel vulnerable, worry about being alone, needing reassurance of someone nearby you to help orient you. And so you end up with anxiety. And so an important thing to know here is that social and environmental interventions are often quite helpful here. It's really a sign that the cognitive demands of someone's life has probably exceeded their cognitive abilities. And so, if you can get a family involved to help take some of that pressure and stress off of them, then that can be really valuable. And then one of the last things I want to touch on are anxiety associated with medical illness. So again, very common and a normal reaction to a chronic illness like cancer or heart disease, but it can also, be a pathological response, and not uncommon in things like Parkinson's disease and COPD, for example. People with chronic conditions who develop a lot of anxiety often have more disability associated with this. And so it again becomes a bit of a vicious circle that they're anxious about their illness, and this makes them more restrictive in their behaviors, and then that creates more disability, and then that makes them more anxious. And so dealing with that vicious cycle is really important. The last thing to just touch on is that, of course, there are medical causes of anxiety in older adults, that hyperthyroidism, hypercalcemia, different sort of metabolic abnormalities can create anxiety-related sensations and this sort of physical discomfort that is anxiety, that creates anxiety. And then things like caffeine, steroids. A classic example from my practice is, an older person who was not very medication adherent with their thyroid medication. They saw their family doctor with a high TSH, and their dose of their thyroid medication was increased. And at the same time, they were put on a blister pack. So of course, then they were adherent to their thyroid medication and became hyperthyroid quite quickly and very, very anxious. And it was only a little while later that was discovered that they were just taking too much thyroid medication. So before I jump into the poll too, before I go into the treatments, I just want to do a quick poll for you again. And so this is similar to before. If you can think about what you have used in your practice to care for people with anxiety, what are some of the common things that you recommend or propose to older adults who you see in your practice? And so I've mixed in, just, I know not all of you will have used medications, but if you are a prescriber, you can indicate medications. And if you're not a prescriber, some of these other interventions. got a lot of people talking about relaxation, mindfulness, and cognitive behavioral therapy. SSRIs are kind of winning in the medication race. Yeah, absolutely. So that's great. So these are really the most common types of interventions that are often proposed for older adults. And it's interesting to see here that antipsychotics do not get much of a rating, although we find in practice that sometimes they do get used when the anxiety is very unbearable. But we'll talk a bit about the evidence. So in terms of the psychological treatments for anxiety in older adults, there have been a number of trials, primarily for generalized anxiety disorder, and most of the evidence is in the area of CBT and mindfulness-based stress reduction. So CBT addresses anxiety by helping people make changes to the way they think and behave when they're anxious, so they can kind of interrupt the worried thoughts and also reduce their avoidant behaviors. We know that it's certainly beneficial in older adults, a little less efficacious in older adults than in younger adults, probably because, there are sometimes some cognitive impairments that can get in the way, and there are adaptations that are necessary. Mindfulness-based stress reaction, it really helps people by helping them focus on the here and the now and develop a sort of open and accepting stance to their worries and their anxiety. And there's a real mind-body response that, from the sort of meditation aspects of mindfulness, decreasing the autonomic response and some of the actual physiological experiences of anxiety. So there are two recommended treatments for anxiety in older adults. And one of the really nice things about cognitive behavioral therapy is that, you can go through for a 12-week course of therapy or a 6-week course of therapy, but you can also use some of the elements of cognitive behavioral therapy. And there is some evidence for this, these kinds of what we call CBT skills. And so you can, in and of itself, use relaxation therapy with somebody, or, do a bit of exposure therapy with someone, or a little bit of behavioral activation. Some psychoeducation, for example, that anxiety cycle for some older adults is so illuminating. They don't really see the, the link between their avoidance and then the worsening of their symptoms over time. And so, these individual skills-based things can often be really helpful. The, important thing is to adapt for older adults. Make sure that you repeat things. So, you go over the same material probably more than once with them. You use written summaries, probably more of a behavioral focus and a little bit less of the more abstract sort of cognitive ideas. And, find ways to help remind them to follow through on some of the activities that you're working with them on. So moving on to the pharmacological treatment for anxiety. So there aren't that many RCTs in older persons. So I'm going to mostly talk about direct evidence that we have in older people, but there are other medications that we know from studies in younger adults are efficacious. But in older adults, most of the studies have been in SSRIs and NRIs. Sertraline is marked as off-label because it doesn't actually have an indication for treatment of GAD, but it is used for treatment of anxiety. Pregabalin and quetiapine are also both off-label. They both have had small clinical trials in older adults with relatively small effect sizes. And quetiapine, even though it was effective, was also poorly tolerated. So that's just something for you guys to know. But really, when we're talking about treating anxiety, we're talking about using antidepressants. And the key points here are that it takes time, that anxiety takes even longer to treat than depression. We talk about depression and SSRI, say often 4 to 6 weeks for benefit. For anxiety, we probably are talking about 6 to 8 weeks before people actually show benefit from the antidepressant. And the other thing that we know is that treatment at sort of the minimal or starting doses is not typically efficacious. And so pretty much in every clinical trial for SSRIs for anxiety in older adults, they had to titrate up to a moderate or dose at the sort of higher end to get benefit. So this was in this clinical trial of escitalopram, for example, there really was no benefit until the dose was increased to 20 milligrams at 4 weeks in the clinical trial. So this, presents a bit of a conundrum for us because we're a little bit limited in the doses we can use of citalopram and escitalopram, which are both very effective SSRIs, but in the clinical studies of anxiety in older adults and in younger adults are typically used in doses at least twice of what the Health Canada warnings indicate should be our maximum doses because of concerns about QTC. So that's just something to be aware about if you're thinking about using one of these medications in older adults, but there are still sertraline, venlafaxine, duloxetine, and not listed here, but known to be efficacious in younger adults is certainly mirtazapine as well. And so like we say, you start low and titrate up as much as you can to as people are tolerating the medication into effect. Just very quickly, benzodiazepines have some problematic issues in anxiety. They certainly work. Clinical trials have all been very short term. We know that there are problems with chronic use. There are real risks of reinforcing avoidance of anxiety and creating this psychological dependence on and you can really perpetuate the spiral by using benzodiazepines. And there's also risks of tolerance and rebound anxiety. So not a great treatment overall. But when you have an individual with a very high level of distress, there may be instances where you might feel that they're warranted for a defined duration with a very clear goal of treatment, short term, with clear informing the patient of the risks, and then discontinuing the medications once the target, once the goals have been reached. And so we really don't recommend that it be used as the sole treatment for anxiety in an older adult. So it might be in short term in the first few weeks while you're starting an antidepressant for treatment of an anxiety disorder, and then come off. So, all right, I got sped up a bit at the end because I was running out of time, but basically late life anxiety, often symptomatic of other conditions, especially consider depression. You want to assess and make a diagnosis. Old anxiety, that's very distressing, is not normal in late life. It's not, expected with aging. You want to treat the underlying condition and make use of these sort of simple, effective, interventions like psychoeducation, relaxation therapy, mindfulness. Start low, titrate antidepressants to an effective dose, and it might take 6 to 8 weeks to work. There we go. I have one more quick slide. If anyone has their phone handy. So we're developing national guidelines for anxiety in older adults right now with the CCSMH, and we love to get your feedback. This is not for you to do now, but like if you can take note of this slide and afterwards the session is done, go and fill out our survey. I would really appreciate it. So should I stop my share, Megan?
Yeah, that'd be great. That was excellent. Thank you. So much useful information. We'll give everybody an opportunity for questions, and there already is one in the chat from Brooke. Is the SAST an appropriate screener to be used with older adults?
What was the SA? I'm not even sure.
Brooke, do you want to speak to your question?
I don't know if I know the SAST, so you're gonna have to put me in.
Either, yeah, I think it stands for Short Anxiety Screening Test. I think, correct me if I'm wrong, if anybody knows. It's what we are using here at St. Joe's Continuing Care Center in Sudbury. We work mostly with older adults, so I just wanted to know if there's maybe something that's better that we should be using.
I'm not super familiar with it, and maybe I'll have to look it up and learn more about it. We just try to avoid some of the ones that are designed for not older adults have the problem that they have a lot of questions that are about day-to-day functioning in the way that aren't necessarily as relevant for older adults, right? So you can get a kind of misleading picture because they say, oh, does it get in the way of your work or your and then the other thing that is sometimes misleading is if they ask a lot of questions about anxiety, about fatigue and other somatic symptoms in a way that a lot of older adults might say yes to without actually being symptoms of anxiety. And so those are, I guess, the things you might want to watch out for. I'll look that up because I'm not super familiar with it.
Thank you so much.
Any other questions? Feel free you can type in the chat, or you can raise your virtual hand, or you can just unmute and speak. Oh, here we go. Carla had a question about, can you see that one? Now that you're.
I'll open the chat.
Okay. Oh, here we go. Comment on the chronic use of benzos to help older adults when they have difficulty sleeping.
Yeah. yeah, so there's like a whole interesting talk we could have about insomnia in older adults. But certainly what we know from clinical studies of benzodiazepines for sleep is that that most of the studies are very short term, that they help people in the short term, but they, that over time they seem to be less effective. People do develop this tolerance to these medications over time. And even when they are using them initially, they tend to only reduce the onset to sleep by on average, about 20 minutes. They don't actually have as much of a dramatic effect as a lot of older adults experience. But, for some people, lying in bed those 20 minutes, not being able to sleep is quite anxiety provoking. And so they like being able to drop off more quickly. There's a whole, we could have a whole talk about deprescribing benzodiazepines in older adults. And there is, a lot of evidence that older adults can come off of those chronic benzodiazepines when they use them for sleep. There's some really great resources on deprescribing.org and some really great resources about how to talk about this with older adults in your practice. It's got to be a very collaborative process. And usually what's recommended is that you just give them some information. So, I don't know if you guys have ever seen, so on deprescribing.org, you'll see them, these great patient information pamphlets about benzodiazepines and sleep. And they sort of lay out some of what we know about how there's not a lot of evidence for using these chronically. There's all these side effects and risks associated with it. And you can, just give them this to your patient and review this with them, and and say, and if you're interested ever in wanting to reduce them or come off them, I am willing to help you with that. And then when you do this, it's amazing. Like half of your patients will be like, oh, I didn't really realize this, and I'm interested in trying, and and so there, it's just a process of like education and like and collaboration really with your patient around whether they'd be willing to try to come off a benzodiazepine. But sorry, I could talk for like I could do a whole 20-minute presentation just on deprescribing benzodiazepines, but that's just a sort of a short sort of answer. But deprescribing.org, some great resources there on that topic.
That's great, thank you. We'll put that one in the chat. The next one is, what is the longest time one can continue taking SSRIs? Is there any side effects of it if one takes it for a long time?
It's a good question. SSRIs are medication class we do have some evidence for longer term use. I didn't show you the slide, but I did have some slides about what happens when you take somebody off their SSRI who had an anxiety disorder, where they had really responded well to treatment. Typically, the recommendation is that if someone is an older adult and has late onset severe anxiety, and they have a good response to their SSRI, that they should probably stay on that medication long term, that their chance of relapsing if they stop the SSRI is probably close to 75% in the year that they come off of it. That's what the evidence that we have so far. But that being said, some people don't like the idea of being on a medication forever. And so it's certainly a conversation that you can have. We usually recommend that once someone's anxiety gets better, they stay on it for at least a year. The side effects of chronic use are, the main one that we get a bit concerned around is around the effect on bone. It's not, dramatic, but that over time, people who have been on SSRIs for, years and years can have a little bit of accelerated bone loss. Older adults, are certainly at risk of this, but, they're depending on how old they are, they're probably not, they may not be on this medication for 10 or 15 years. And so it may not be as much of a concern. And, you can certainly address this by making sure that you manage any, do their osteoporosis prevention and management. That would be the main sort of risk factor of chronic SSRI use. There is also a risk of falls on SSRIs. Like any medication that we prescribe or give to someone that affects their brain also affects their risk of falling. And that's also true for SSRIs. But, when we do the risk benefit analysis, in general, people are happy that when their anxiety is treated and they're happy to take that risk.
Nicholas had a question about recommendations when SIADH is a problem. What medications do you usually use?
So that for those of you who don't know SIADH, that's when some older adults are at risk of developing very low sodium when they go on antidepressant medications, and that can be actually life-threatening. Sometimes it can make them very sick. And so there are some antidepressants that place people more at risk of SIADH than others. We would, in those cases, we would just try to pick SSRIs likely to cause it. And so, the typical one that we go to is mirtazapine. And so that's often an option. Buspirone, I think, has a slightly less, and so that's a medication that's not an SSRI, but has evidence for anxiety in older adults, and that would be one that has a less risk of SIADH. So you're just kind of at that point sort of dancing around the main ones and looking for alternatives that are less likely to cause SIADH. You can also, at the same time, see if you can figure out if there's something that's contributing it to it, like if they're on some water pill or something else that is making it the SIADH more likely. But there's not always an obvious culprit. So.
Thank you. Yeah, I haven't seen anything else pop up, but if a question comes to somebody, feel free to pop it in the chat or raise your hand. We're going to move on to our case